Hello everyone, my name is Jun Sung Moon and now I'm working at Yeongnam University Hospital, Daegu, South Korea. I'm mainly taking care of patients with diabetes and general endocrine disease, and my research interests are clinical diabetes and islet biology. And I also serve as a secretary of the Korean Endocrine Society Committee of Training now. I appreciate to ISE for giving me an opportunity to share our recent experiences about COVID-19 pandemics. By the 14th July, the Korean government reported the total confirmed cases are about 13,500, and the positive rate is 2%, and the mortality rate is 0.02% among tests performed. Although around 50 cases are reported every day during recent a couple of weeks, it seems to control relatively stable. However, last March and April, we experienced a massive outbreak in our country, especially in Daegu city I live. In mid-February, a terrible situation began with a super spreader, and hundreds of confirmed cases occurred in Daegu every day for more than a month. We faced a crisis at that time because of a shortage of hospital beds and medical staff, but many bits of help and volunteers from over the country saved our city. Fortunately, we didn't have any experience of the medication shortage as well as toilet paper. I would like to thank you again for the voluntary dedication to help us. In principle, the Korean government did not permit telemedicine because of safety concerns and opposition from doctors. But this urgent pandemic situation, patients were afraid to visit hospitals, so the government temporarily granted permission for managing chronic disorders such as diabetes, dyslipidemia, and hypertension. This permission included telephone interviews and repeated prescriptions for their prior medication. Of course, telemedicine was only allowed under the condition that the disease was being controlled stably, and the government and healthcare providers advised that patients should be visited if their glycemic control or blood pressure is suddenly changed. During the outbreak of our city, Daegu, only less than half of the patients visited my office, so I was less busy compared to before the COVID-19 era. I think this strategy is inevitable if this pandemic is not ended soon. Telemedicine minimizes unnecessary contact, reduces the exposure risk from uncertain infection source, and finally make both patients and healthcare providers safe. However, we should remember that telemedicine is not perfect. It's not replaceable for the physical examination and emotional contact between physicians and patients. For the preparation of another new epidemic in the future, technological advances such as high-resolution cameras or portable diagnostic devices are essential for the complement of current telemedicine. Yes, I also agree with these kinds of unexpected concern. I would like to share the unfortunate case I recently experienced. He was a 57-year-old male patient with diabetes, chronic kidney disease under peritoneal dialysis. Last October, he admitted our hospital for diabetic foot wound and discharged with successful management. At that time, his HbA1c level was 6.8%. But unfortunately, he was diagnosed with COVID-19 this March, and he had no choice but to be admitted to another hospital due to the bed shortage in our hospital. So he was limited regular exercise and outside activities. This patient was recovered from COVID-19, but sadly, he developed a new severe diabetic foot infection with poor glycemic control, and surprisingly, his hemoglobin A1C level increased to 10.8%. He told me that most of healthcare workers had to take care of severe COVID patients and not enough to care for another comorbidities such as diabetes and hypertension. This patient could not get enough care to control his blood pressure and hypoglycemia during the COVID-19 outbreak. From this tragic case, we have learned the lesson that overwhelming outbreaks of acute epidemics can destroy the medical system for non-communicable disease. In my opinion, all endocrinologists should not only protect endocrine patients vulnerable to infection against COVID-19 through social distancing, but also make public efforts not to collapse the healthcare system. About the people stay home, now my colleagues and I are trying to analyze whether the self-quarantine worsened the glycemic control in diabetic patients or not. Interestingly, we found social distancing or self-quarantine increased A1C levels compared to the same period 1 and 2 years ago. Therefore, these strategies are inevitable in these situations, but at the same time require constant efforts to control the underlying disease of the patient. Anyway, to date, there is no evidence that certain medications affect COVID-19 infection and outcomes, so patients should be educated to never stop medication and keep their lifestyle healthy indoors.